Good afternoon, everyone. I'm Dr. Sudeep, consultant pediatric cardiologist, KIMS, Cuddles, as well as KIMS Kondapur. Now we are just today for the what the pediatrician neonatologist needed for the echocardiography. I'll just share the presentation of half an hour. Then we'll go to the bedside to see what are the views and how we are to see the assess other things. I'll go in fast because we need to see the live patient also. See, these are the various case scenarios. Whenever we go to any neonatologist or pediatrician, they will ask whether we can give more fluid or not. So first, we need to fluid the fluid assessment. That is very possible. These are the things which any pediatrician neonatologist will know, whether PD is present, whether to confirm whether the hemodynamic is significant PD or not. And nothing I am seeing when I am seeing the heart, some neonatologists, they will try, but they're not able to see. Then what may be the reason for that? Any collection, what are the function and what are about the PA pressures, and whether my line, cannula, ECMO catheter, UVC, everything into the position. So these are the 5-6 most common case scenario. So by showing you these, I am telling you as a neonatologist, you should know whether we should give fluid or not, what is the cardiac contractility, whether PDA is there or not, the right to left to right, or bi-directional, whether we have to give the closer for the PDA or we have to start nitric oxide for the high PA pressure right to left PDA. And when we should know when we are not able to see, the heart should be lower, other position, or some pneumothorax is there, and whether any collection function. Why I'm telling you these are the common things. If you know 80% of the cardiologists work cardio, because as a cardiologist sometimes they're less cardiologists, so they are unable to reach, so everyone will get pissed off with that because they're not coming on time. So be independent, be self-dependent, and then learn the few things so that it will help you for your clinical practice. So this is known as ABC of echocardiography. The same way, once you start learning the motor vehicle, now even the automatic accelerator, brake, clutch, so there's ABC for like that also. In the same way, there is a ABCDEF of echocardiography. First, you know the anatomy of the subject, basic of physiology, what are the buttons. There are so many of buttons like in mobile, but you don't need to know anything, all the things. You should know only 8 or 10 specific and most common buttons used for that. What are the circulation, clinical setting, and history? This is the most important word. Sometimes as a cardiologist also, when we are doing directly echo, will not able to check that with the neonatologist or pediatrician. Dynamics of echo, what are the physics of echo? Equipment, and what are the echo machine? Which echo machine? What are the probes? And what are the function echo to see the cardiac output as well as the fluid status and function? So this is not the ABCDEF of echocardiography. So there's a rules and regulation for anything, for any needs knowledge of basic erectance physiology, basic knowledge of echo screening. All users must never break this rule, because if you sometimes I'll tell you the initial of my example, I not check the descending aorta Doppler. I found out there is a descending aorta obstruction, there is a thrombus in descending aorta. So you should know the all rules. If you're not doing suppressive way, means the coarctation. So there are so many things. Never be overconfident. Every science is unique and no one is perfect. Even the best cardiologist may miss the sometimes simplest things. So when you are not able to take ashamed to read, don't be feel ashamed to recheck and to take the second opinion from other ones. So these are the basic rules, and don't presume structure. Suppose you are not able to see LPA period, don't presume it is there until you are unable to profile. So always correlate with case scenario. So point of care echocardiography, that is also well-defined purpose linked to improving care of patient, focus and goal directed, quickly performed at patient bedside. So this is know your probe and machine panel. So these are the two things. These are the machine. This is the machine. You can see what are the probes. So there are so many probes, but you don't need to know anything, but you should know the basic physics of the machine, where the screen is there, where are the buttons, how to change it. Okay, so there are, to start with, there are 4 probes. Curvilinear probe that is used for auscultation as well as abdomen, as well as for the fetal echo. Linear we use for the vascular structure. Endocavity, that is for vaginal rectal. And the most common C-shaped small cardiac probe that is used for the echocardiography. The same probe can be used for the neurosonogram also. That's why in the neonatology, the same neurosonogram probe can be used as the fetal echocardiac probe also. So if you see, there are so many numbers are written. So there are 2.5, 5, 10, 12. So what does it mean? Higher the number, the frequency is higher. That means the penetration is less, but the resolution is very high. What does it mean? Suppose neonates are smaller the baby, more the frequency required. What does it mean? In a neonate, you have thin skin. So even the 12 probe, although the penetration of that 12 probe is not good, the resolution is very good because there is no fat or fascia not thickened or no muscle. So you are able to see very good resolution. In the same way, in an adult, if you do with the 12, nothing will be seen. So you have to go with the 2.5 or 5 probe because that is what the more penetration, although resolution will be less. So as the lower age, more frequency probe is needed, which is having the more resolution but low penetration. As the age grows, the resolution power of the probe reduces, but the penetration increases. So this is the in general you have to see the probe. So high frequency probe for which is a depth of 4 to 5 mm, high resolution, but the low frequency probe for adult get a depth of 12 to 16 centimeter and get the low resolution, not high resolution by mistake. So low resolution. Okay, so this is the probe you can see. This is the marker. As a marker you have to see on the left side, and the same the screen marker also should be on the left side, that will show. And you should see the jelly. Why I am doing with the hand? The jelly should be warm. Sometimes when we are putting a small, we are just putting the cold jelly, that will cause the spa, the baby will come wake up. So you should be a cold jelly. So as a protocol, we are putting a warm jelly and then we are putting that. Second thing, you have to sterilize the probe very properly. One of the very good caution what I learned from my neonatology colleague, never use the jelly in neonate. Use xylocaine, because jelly you are keeping and putting in the that it will get infected. So better to use the xylocaine jelly, which is get less infected, it is get finished very fast. So better to use xylocaine jelly, and then you can go ahead to avoid the more infection by the probe itself. So this is the general concept. See, there are two things. Doppler. What is a Doppler? Doppler is because the sound principle. This echo depend on the piezo crystal, which is emitting the sound wave, and the sound wave is going towards the patient, and whatever structure they are reflecting the sound wave, that is again they are catching. So if you see this, the first one is the pulse Doppler. Pulse Doppler will go at one time, it will send, and then again after some time it will pick up. So it will pick up only low frequency, while the continuous wave will continuously giving the waves and they continuously picking up the wave. That's why they are able to get to, when there is more graded like aorta, stenosis and all, then we want to measure that, you need CW. While in the low graded like pulmonary vein or something, or pulmonary vein IVC, you can use that graded. So that is the importance of the pulse wave as well as the. So what is the advantage? Pulse wave, it will interrogate. There is a sector, there is a dot on the line, that is a pulse wave line, that is known as sample volume. So wherever you are putting the sample on a pulse wave will determine the pressure only at that area. But the continuous wave over the whole track of that line, it will get up there and give the average of all that. So that's why once you want to locate out of the whole tube where is the obstruction, you can use the CW, but when you want to see where exactly the location of obstruction, you can use the pulse wave Doppler. Okay, so this is the very, and this is one of the most common question which asks what is the red and what is the blue mean. So see, lower I showed there is a probe position. The probe will give the sector like the triangular sector, where the end of the apex of the triangle, that is the probe position. And you should always see the mark what I showed in the beginning should be on the left side. And what the red towards, red means any flow which is coming towards the probe is red, and any flow which is going away from the probe is blue. So blue and red is not being of oxygenated, non-oxygenated. That is one of the most common mistake, and the myth is there, but it's red towards the probe and the blue is away from the probe. Okay, this is a simple. So now there are two, three things. Once you go to the bedside, I'll show the knobs also. But as a knob, depth, you can increase the depth, zoom, you can zoom that structure, CW, PW, color. So if you able an upper and lower inversion as a right and left, if you are able to do an PRF in scales, so if you are and gain, if you have only 7 things, if you are able to maintain the understood, that means you are able to do 80 to 90% of the echo thing. So now first the chamber and vessel identification. So atria, the 4 chambers you all know, RA, LA, RV, and LV. So atria is determined by the flap. Suppose this is the flap. So wherever the flap is there, margin of the flap, that is on the left side. Suppose your flap is like this. So that means this is the left atrium, this is the right atrium. This is the first way. Suppose you are able to see the PFO. Second thing, you have to do the appendage. It's very difficult sometimes, but whenever there is a long snoopy long appendage, that is L appendage, broad appendage is R appendage. And for your thing, wherever the IVC is running, although very rarely IVC may turn abnormally also, where the IVC is running, that chamber is the RA. Okay, so these are the things for RA. You can see this. So what is the meaning of showing this? So now RA, LA, you should know RV and LV. So you have to remember, if somebody asks what is RV, the RV always go with the tricuspid wall and LV always go with the mitral wall. So if you see in this, see this is the view. You see this is the very irregular surface. The septum is irregular on the RV side while it's smooth on the LV side. The RV wall, that is tricuspid wall, is always lower than the mitral wall. That is known as offsetting. Both walls are not at the same level. Tricuspid wall is little lower, so that is known as more apical, or apical portion, lower portion is compared to mitral wall. That is the RV. Okay, and second thing, this is C. This is the very white structure seen at the apex. That is known as the moderator band. So more irregular. This C, and if you see the tricuspid wall where the arrow yellow is there, that is more touching the septum. So tricuspid wall is more apical, more touching the septum. You can see here with this windows. See this one is attaching to the septum more, so that is septophilic, that is tricuspid wall. On the left side, it's little away from septum. This is not that septophilic. And the irregular IVS margin on the RV side, moderate event is on the RV side. And see, these are the two levels of the wall. The upper level is mitral and the lower level is tricuspid wall. These are the, so you know RA, you know LA, you know RV, you know the LV. Now the two vessels which is coming, how to determine? This is very important thing. The aorta will give branch when it go to the neck. So aorta will never do early branching. Whenever you are saying the early branching, so wherever the coronaries are attached, if it's not Alcapa, if the coronaries are attached to that and it's not getting early branching, that is aorta. So, but if you see the early branching in aorta, that may be the truncus or the one of the PA pulmonary arteries coming from the aorta. On the contrary, pulmonary artery will immediately bifurcate. You can see in the lower, the pulmonary one is short. MP is always shorter than it will get immediate bifurcation. So early bifurcation, short MPA is a characteristic of MPA, while the elongated structure giving rise to coronaries and the late branching in the neck is the characteristic of aorta. So you can see this. See, this is the PA. You can see it's getting right and left early branching. Okay. So now what are the views? So now if you see, these are the views. You can see the marker is not seen. Marker is on the left side. This is the baby where we are showing the how to put in the apical region. So this is the, will show all those. What are the reasons? There are four basic views. Apical view, that is for the four chamber view. Subcostal, which is for your IVC, SVC, atrial septum. Parasternal long axis. You can see this. Okay, in the middle panel, this is the parasternal long axis. So that you have to see. Okay, so that I will teach you there. But these are the various positions. This is the position for the subcostal. You can see in the subcostal. Okay, and this is subcostal. So now, if you know the RILV, one of the very important finding you can see on the left where LA is marked. The LA, there is a something coming that is known as the Comedian ridge. Okay, what I want to tell, there's a ridge is which is seen in the white color near the LA, that is Comedian ridge. That means there is some ridge is present in the LA. So that is suggestive of there is a pulmonary venous drainage. That's why you see the LA border, LA roof is irregular, it's not smooth. But whenever you see the smooth, nothing is coming into, that is the suggestive of pulmonary venous drainage, abnormal pulmonary venous drainage. That is known as the bald LA. Because the veins are not coming, it will give the not corrugated appearance, it gives the bald appearance, that is known as the bald LA. So you can see these are the various examples of the TAP. You can see this is the confluence. If you see something behind the LA, there are only two things, either pulmonary artery will come or the confluence of the pulmonary vein will come. And if you see the, I'll show this actually, this one very important thing. See, the aorta will lie exactly behind the LA. So if there is a gap between aorta and the LA, then definitely there is a pulmonary venous chamber. So this is the one of the characteristic finding of the finding. Suppose this is the, now how it will help with the general clinical condition. This is a reticular pattern in a term maybe not improving with RD is not improving surfactant, and then we found out. So you can see the reticular pattern in a term baby is always. So you can see once you view from the IVC, put your probe vertical, then go from towards the left side. So initially you will see the IVC because it's going to the RA. Then if you go, you will see the aorta. IVC flow is from the lower to the up towards the RA while aorta is flow. But if you see anything in between, going between IV center, that is always abnormal. That is a very characteristic of TAV. We see sometimes scimitar vein. Okay. So now this is a one patient where the severe TR is there, the severe PH is found to be TAPVC. Okay, this is not for you. See, and one of the very good thing, whenever you are, see, once you see the four chamber, I'll show on the table on the live K. Once you do the four chamber, do anterior sweep because aorta is more anterior and the PA is more anterior than that. So once you go, the both vessels is not seen in the same view. So this is a very important point. See what I mean to say. This is the anterior sweep. You can see the fourth chamber. Now some valve is seen. That is the aorta. And once you go more and more anterior, very anterior, like that your probe will go more, then you will see the pulmonary artery. On the contrary, if you are open and both aorta and PA seen in the same view, like in this, you can see this. See, LA, LV, PA and aorta, they are all seen in the same view. That means it's a typical of the TGA. So that is the parallel circulation. So what does it mean? Ki both outflow should not be seen in the same plane. It should be seen in the different plane. So you see the aorta will go and PA go like that. It will cross over. So that's why they are not seen in the same view. Because aorta will go from posterior ventricle to the anterior, and the PA will go from the anterior ventricle to the posterior. They will cross. But if they are seen in the same plane, that is suggestive of TGA. In the same way, once you do the suprasternal, I will show how to do it. So one of the clue, all three vessels are equidistant, first, second, third. But if the distance between two vessels increases, that is the indication for the coarctation. So you have to see like this. That I will tell you how to see that. Okay, this is the PS that we all will discuss this. Okay, so now any wall like a pulmonary aortic, it will open like this. Okay, but if it open dome, like it's a dome, that is means it's a stenotic wall. That is one of the criteria. Okay. See VSDs and all I'll tell you. Okay, so these are the various views which we can tell. Okay, just for the sake of completion, I will tell. See the both walls. If you see, this is the both. This is a one patient where the walls are not seen. The one of the leaflet will go very down on the right side. That is typical of Epstein's. Second thing, see this is the Epstein's where the wall is done very because the septal leaflet is not seen at the high level. It's seen near the moderator band. That is the Epstein's. In the same way, this is once you see the long axis, any dropout below the aorta is a characteristic of VSD. In the same way, any mosaic pattern, it should be like what is in the scene in RP, it should be smooth pattern. When it became mosaic pattern means there is a turbulence. Then you will see the orange or yellow, that means that is a turbulent flow. So that is because of the stenotic lesion. So here you can see the turbulent flow in the short axis from the pulmonary wall, and that's why it's a pulmonary wall stenosis. Okay, in the same way, you see various views, short axis. So if you see the short axis, the very good thing, the short axis, anything which comes in relation with the aortic wall and the tricuspid wall, that means at the 9 o'clock position, it's a perimembranous VSD. We have the 11 o'clock, it's a subaortic or intraconal VSD, which is at the 12 to 1 o'clock, it's a subpulmonic VSD. So with that, any VSD like this, which is not seen up, but it's seen with both AV walls are seen, that means it's an inlet VSD. So these are the various things what we can see. So VSD, we have to see in relation with the tricuspid wall, perimembranous 9 o'clock position, it will see pulmonary wall, it will see at 1 o'clock in short axis. In AV wall, in apical fourth chamber, it's an inlet VSD, and which is not in relation with any of the wall, it's a muscular VSD. You can see in the same way, once you do the use a subcostal, you will see the dropout. Never comment ASD on a fourth chamber because the waves are coming directly perpendicular. It will give a false dropout. You have to go from the subcostal because the wave will be perpendicular to that, and you are able to see the dropout. So it's a typical Austen secundum ASD from subcostal view, and there are various kind of Austen. So now this is in general. We'll show the on live on the patient. But now one of the very common questions, what are the PA pressure assessment? There are various ways to do PA pressure assessment, like TR gradient, PR gradient, like any shunt is there, you can take the shunt gradient, septal movement and RV cavity. Okay, these are the four which is most commonly used in, as a pediatrician, you should know that only. What is the meaning of gradient? I'll give the example. Suppose 10 people are outside the gate and 40 people are inside the gate, and somebody tells there is a difference of 30 people between outside and inside gate, and the outside there are 10 people are standing, so you can automatically know if the difference between outside and inside gate is 30 and outside 10 people are there, so automatically you come to know the inside there are 40 people. In the same way, when you are taking the TR gradient, suppose TR gradient comes 30, that means there is a pressure difference between RA and RV. So 30, if you add the RA pressure, so how to add RA pressure? When the IVC is not dilated, 8-10 to that. So that will be the RPA systolic pressure or RV systolic pressure. Okay, when the IVC is very dilated at 15. So that's how you know the TR gradient plus RA pressure of 10 in collapsing IVC and 15 in presence of dilated IVC will be the RV pressure. So in absence of pulmonary study, their RV systolic pressure is equal to PA systolic pressure. Indirectly, you come to know the PA pressure. Second way to do it, whatever TR gradient, suppose you got 30 and you add 10 in that 40, and now your systemic pressure is 60. That means as compared to systemic pressure, your PA systolic pressure are 2/3. So any pressure which is 2/3 or more than a systemic is a severe PAH. Any PA pressure which is up to 50% is mild PAH. 50 to 2/3 of the systemic pressure, PA pressure is moderate PAH. So there are the two ways to do it. Second thing, this will be only systolic pressure. In the same way, when the PR gradient you are taking Doppler, the peak PR will correspond to the mean PA pressure. So I'll show this. This is a TR gradient. Suppose it's a 90. That means in the presence of IVC collapsing 90 plus 10. That means the RV pressure or PA pressures are 100. In the same way, this is a PR, peak early diastolic velocity of the PR. That means there's a mean pressure, and the end diastolic of PR plus RA pressure will be the and PA diastolic pressure. The PA pressure, three things: systolic, diastolic, and mean. Systolic you will get with TR, the mean you will get with the peak PR, and the diastolic will get with the end PR. So these are that's why systolic PA pressure, TR get with the RAP. Okay, or suppose you have some shunt like you have VSD. If the VSD gradient is 30, that means LV and RV pressures, the difference is 30. So if you know the systolic pressure, suppose systolic pressure is 90 and the gradient between VSD is 30, that means RV pressures are 60. That means almost it's a 70% of the systemic pressure. So it's a severe PH. In the same way, PDA, if you take directly PDA pressure 10, that means there is a 10 gradient between PA and aorta directly. So that means if your systolic pressure is 80, then your PA pressure will automatically become the 70. That's how you are able to get in presence of the shunt. Okay, so these are the things. Okay, so now suppose this is the normal chamber. What happened? The RV in adult, the LV is the more or the bigger side. The LV bulge is towards, you can see the septal bulge is towards the right side. But when the septum becomes flat or it becomes bulged towards the LV, that means the RV pressures are very high. So once in the chamber in PH, initially the septum becomes flat and then it becomes towards the, suppose this is the RV and this side is LV. So initially septum will be like that. Once in the PA pressure high, it becomes straight, and then it's a severe PH, it becomes the convexity towards the LV. So this is one of the proved method to see the PA pressure in when you are not having TR or TR graded. Second thing, when you are seeing the shunt, again you can see your probe is down, your triangle is coming from the 6 o'clock position. So that means PFO is shunting right to left. That is always abnormal. Okay. So this can be seen in normally sometimes intermittent of 1-2 days, which is such a high PY. That means in that case you can give the NO and you can give the sildenafil. But if consistently beyond that, they would think of the obstruction like critical PS or TAPVC, RV dysfunction, tricuspid atresia. Now, two last thing, then we'll go to the patient and we'll give show like cardiac output measure. What we can is a continuity equation. What we are expecting in suggesting when the blood comes to RV, the same blood with the lung in absence of any shunt will go to the LV. So if you measure one of the flow, automatically you can get the flow at the other. That is known as the continuity equation. And second presumption, we are making the LVOT is circular. If it's a circular, we consider it as if you take the diameter of the annulus, aortic annulus, and if you make it half, it becomes radius. Then you can get the pi r square area of that. And with that, you can see like lower. You put a pulse Doppler and trace the Doppler tracing. So that is known as the VTI. So if you measure first annulus, aortic annulus, then make it half, make it pi r square, and so that will be the LVOT area. Okay, and then that VTI, you have to VTI, the trace of that, if you multiply with that, you will get the stroke volume of the single beat. Multiply it with the your heart rate, then you will get the in 1 minute. That is the cardiac output. And if you multiply the body surface in the same, you will get the. So if you see, this is the one example. See, first patient, you can see there is a tracing. tracing on the Doppler. Okay, then what we are taking annulus, and then Doppler we are taking. In annulus, then you are measuring with that VTI into of that. So area of that tube, so that you able to get the cardiac output. Okay, so now other thing is the M mode. We are getting at the tip of the mitral wall where we get the LVIDD and LVIDS during systole and diastole. Systole, it will be lesser volume because heart will contract. So you can see the leading edge to yellow is there is the diastolic because it's the maximum volume, while it the green is the systolic volume. So with that, the machine will give the correct measure. If you do, there is the EF button that will show that. Now the fluid responsiveness. So suppose you see the place probe at the subclavian pointer vertical, you can see. This is the video. You can see the IVC. I am showing. So in that you can get up two things. IVC will always go into the chamber while the aorta from up will go higher. So there are, if the two tubes are saying whichever tube is culminating into the chamber, that is the RA. If it's going beyond, that means either the aorta. If you see with the hand movement, the IVC is draining and it's a totally collapsing. Even with the variation, it's not changing its much. That means you can give the easily fluid, you can give more fluid, but it's a very dilated. There are objective criteria also, but as a pediatrician, if there is no phasic variation of 50 more than 50% or more, that means you have to restrict the fluid. If the more than 50% variation, aramly you can give the fluid. So these are the, you can see upper also. See, that is a dilated, but it is still a collapsing. Okay, the IVC, that means you can still give more fluid. But there are so many other things are there which we can tell for the infant, but not validated for the neonate. You can extrapolate when the IVC near total collapse, your RMS is only 5, up to 50% decrease. It's a CVP is 5 to 10, less than 50%, that means 10 to 50, no collapsibility, that means CVP is more than 20. So these are, and that is a separate thing, more than 13% difference or 9% difference with the leg rise or change in the position, then if they, that means that is the on ventilator and the without ventilator. So now which is that, these are the, and now the PDA. PDA is a special view, you have to keep it here, that is known as the ductal view. There are various, but as usual, the LA aorta ratio as well as the PDA to LPA ratio, PDA to the body index, and then PDA diameter absolute. These are the criteria for the direct asset. Less than 1.5 is small, moderate is 1.5. Ratio of PDA to LPA diameter less than 0.5 is small, moderate is more than 0.5, large is more than 1. And then the other surrogate like excessive pulmonary blood flow, there are various LV outflow and LPA flow that is not, we cannot cover, but these are the criteria where we can, there is a more flow going to the pulmonary artery as well as to the PD, from the PD to the pulmonary artery and then coming to the LALV. So these are the 5, as a neonatologist you should know the 5 pattern. If you put, I'll show how to put the 5 pattern. Okay, so this is known as the hypertensive pattern, growing pattern, pulsatile pattern, closing pattern, and totally closing, 5 pattern. Once you get any continuous with the big difference like the pulsatile, this is, if any preterm will get the pulsatile, that means it's a significant shunt. Whether you will do the other things or not, first this pulsatile pattern. First pattern hypertensive, that is for the PPHN or the in normal patient also in the first 1 or 2 days you will get it, and when it's a close you will not get any flow. And with the B is the growing pattern. That means if you do that, you may expect is to grow, come to the pulsatile or closing pattern later on. So it's a hypertensive, growing, pulsatile, closing, the 5 patterns are there. So these are the flow pattern different. Okay, so Doppler pattern of DA flow we already explained. This is, so you can see this is the PD. You can see that is not tripod. These are the blue 2 are seen as well as the third is seen the blue. You can see this is the, and second thing in the Doppler also, like you are seeing in the flow, if you're putting the Doppler in the baseline, whatever Doppler is flows coming towards the probe will show above the baseline and coming away. Like this is the blue, and our triangle is from the up. That means that it's coming away from the probe, going away. So that means the lower one is the right to left shunt, upper one is the left to right shunt. So in the same way, you can see this is totally, and this is 3 things are in that, you know, the tripod sign of the PDA. So you can see sometimes pericardial collection you can see, and this is a large pericardial collection you have to see. So where is the heart? Sometimes you are not able to see. So that's why your clinical judgment is very important. See X-ray. Sometimes heart is not seen, that means it's not there. That means it's on the dextrocardia, mesocardia. Sometimes CDA, that will displace the heart, or sometimes there's the air around the heart, which is a very bad conductor of sound wave. So that's why in the pneumothorax also you may not able to see. So what are the other cause like that? This is the pneumopericardium where we are unable to see the heart, and that is the large pneumothorax which will push the heart towards right side, and we are unable to see the heart. So you can see this is the function very poor. This is okay. See like this. This is a very big heart on the X and the eddy matters, but you see there is a very high flow coming from the SVC in the bicave. It turned out to be so. Whenever you are doing, we are unable to see as the echocardiographer see put on the brain, put on the liver. We diagnose so many hepatic AVM as well as the renal as well as the vein of the limb. Just because of that, we are unable to get why the PAH are there. Okay, so it's like a, if you see echocardiography, it's like a big thali where everything is important. It's a gamut of everything. It's like a quiz. You have to take help from the X-ray, ECG, your clinical, your Doppler, your echo machine, everything, and then you come up to the big conclusion. So in that, it's always a learning curve. Whatever new thing you will see, you will have always a learning curve. You have to go always better with the time. So do with the more ICU and ventilation so that they may not move. So as a for all these are start, you have to be quizzing yourself why this finding is there, why this finding is not coming, why this finding is coming, why I'm unable to see. So these are the all various mystery and the detective character. You have to get some inclination from them, and you have to try to fit everything into one thing. So thanks, have a nice day. Now this is in general a small synopsis, and now we'll go to the patient side and we'll show you what how to do the basic echo and the other things what we learned out. Thanks a lot. So now we'll go to the patient side and then we'll show you.
Camera is fine, sir. Negative feedback.
live. No? For sure. It's a live now, no? Continuing, no? So now we, after getting the some inside view, now we'll come to this is the machine. This is a small bedside machine, but this is very good machine. You can see there are various probes. So this is S12 probe. The S12 probe. This is got very good importance because this is for the neonate. In the same way, for the adult or the bigger kid, the S5. Here, the penetration will be more, but the resolution will be less. In the contrary, this has got more penetration, but less penetration, but more resolution. That's why for the thin skin, like in neonate, where the fat is less and muscle is that we can easily use it. Second thing, this is the marker. It should corroborate with this. Okay, here, how to change it, you can see.
But it's not considered. మళ్ళీ లైవ్ షేర్ చేయండి కదా.
Again, we are live. So now, sorry for the interruption. Now we are in continuation with the what we saw in the PowerPoint question. That is just a small synopsis. Now this is the patient. You can see one of the patient which is lying in the bed. Ventilated is the best patient to learn because they won't move. If some move also, you can give some sedation and do. And this is the machine. You can see small machine but very good. There are two probes. You can see one probe is S5 and this is S12. S5 probe is having the more penetration but less resolution. Right? S12 probe is having more resolution, less penetration. That's why they are suitable for the small babies, like where there is a less fat as well as less muscle. So even with this probe, you are able to see good picture. Nowadays, we started using xylocan because if you put this, we are keeping this like the source of the infection. We got so many of the patient got same infection what is lying in this. So better always to use the xylocan what you are using specifically separate for all unit, and then you do. And they should be warm sometimes, you know. And now this is the pro marker. This should be on the left side. It should corrobate. See here it's the right side. That means it's wrong. So in the machine, the up left or left side things are there. You see like that. So now. Okay, so now this has to be there. This is the probe. That means wherever it's going in the fan and the triangle base of the apex of the triangle is the source of your. That means that its generation of the sound is coming from that, and then it's going as a plane. Okay, so this is the one thing. Now you see simple things here. 2D means 2D echo. C means the color. Once you put, you will see the color. Doppler. And once you put a Doppler, you will see the pulse here and the continuous. So what is that? And this is the sample volume. Okay, then what is the importance we shown? This is the M mode. That means you to get the M mode. This is the one thing. This is the freeze. Okay, and whatever you want to do, you can select the measurement, everything. You can go select in with the caliper. So if you know these things, and second, this is depth. You can see. I'll show all these again. But if you and this is the gain. That means nearby gain, far and overall gain. Near gain means near to the probe, and the far gain means far from the probe. If you know all those things, that means if the 7-8 things, if you know, that means you are able to go. See. This is the probe. Now I'll go with the one thing. Can you please remove that? Okay, now we'll go with the everything. 4 things. First, the chamber localization, pressure, IVC, and the catheter. All those things we'll see. So this is the patient lying. You can see. This is the probe. Either you can put it up or down. So this is a subcostal view. Okay, you can see here. See what I am doing. If I want to see low upper and the lower. Now, see this is the IVC which is coming. It's a very dilated IVC. You can see. Okay, once you see something like this, that means it's a sluggish circulation. So that is because of the low cardiac output or polycythemia. Okay, now if you want to see, put a M mode at the IVC. See, this is the IVC lumen, but it's getting more than 50% variation. That means still you can give more fluid. But if it's no variation, that means it's a very stiff, so you cannot give more fluid. So this is the first thing. In the same way, what I am showing, first you will see the IVC, you see my hand movement now. Now I am going towards the left side. The another thing is seen as a aorta. If I come to the right side, IVC, aorta, IVC, aorta. IVC is on the right side, aorta is on the left side. If third vessel come in between any other vessel which is vertical, that means that is a descending vertical vein which is seen in the TAPVC. Okay. Now you see there is some catheter, and we know there is a umbilical artery catheter is there, so we know there. You can see the catheter into that. Okay, so this is at the higher position. Above the diaphragm is the level of UAC at the higher position. So with that, even you can know the UAC is at the high level position. There are two levels, low and high. In between, we are not putting. It's a high level, that is a correct position above the diaphragm. That's the first thing. Now, second thing, I'll go with the subcostal. You see this probe, this marker should be at the left shoulder apex. See. Now you can see the four chamber. Now I'll show the live. See, this is more corrugated. This is smooth. This is having moderator band in this leaflet. This leaflet is lower and more septophilic, means it's more touching the septum. See, now you can see this is more touching the septum. So this is tricuspid wall. Tricuspid will always go in hand with the chamber. So this is RV. You can see this is the moderator band, lower level of the RV. This is the LA. This is LV. How will know this is LA? You can see now what I am showing. This is known as the Comedian ridge. So if these are there, this will rule out your TAPVC. If the Comedian ridge is, that means at least minimum one vein is coming. And if it's not TAPVC, that means that is the LA. Okay. In the same way, if you see the subcostal, the IVC is coming to the right sided chamber. So that means in all case, for your level, if IVC is coming to whichever chamber is the RA chamber. And you can see the flap. I will show the flap is not seen here of the right. And now, so these are the four chambers. See. This is the more septophilic, more apical, more trabeculated, and the moderate was this RV. And this is the LV. This is the false tendon. This is the LA. This is Comedian ridge and the pulmonary vein. You can see there is an irregular LA margin. That means the pulmonary veins are coming normal. If it's a very smooth or bald, that means a TAPV. Now see my hand movement. See, I'll go little anterior. So I am open one of the outflow, but this outflow is not giving branching. You can put a color. You can see this is not giving branching. And once you go this and see, they are not seeing the one. See, this is one way, and then I am going more anterior. I'll show here. With more anterior, you can see this is a pulmonary valve which is early branching. This is short, and this is the early branching. See, it's getting branching early. So that means this is LV, which is giving right to one of the vessel, which is elongated going towards the from left to right, and this is the another vessel from that which is going. This is the early branching. That is the pulmonary artery, and this is the aorta. Second thing, now with the color. Now with the color, if you see, now what I told, what the blue color means is the away from the probe, and right is, suppose this is your position. So this is your probe position. So RA to RV, it should be always red only. And from LA to LE should be red. But some blue is also coming, you see, which is not normal. From the LV, from the RV to RA, there is some blue flow that is known as the TR. And in the same way, from the LV to LA, there is some blue flow that is suggestive of MR. So now this suggests your flow. Now again, we put a Doppler. See, Doppler, this is a sample volume. Wherever that flow is coming, you have to put at the point, so you will get the better picture. So what is if I put P wave? I'll show you. PVOC, it show only low pressure. You may not able to see in one screen. The same if I change to, because it's only for the low pressure system. Now see, So it's a blue. See now it's, and you can do the scale. This is the scale. Then on a PRF. It's not coming for baby move. See, this is a good, okay. So blue, that means it's coming below the line. So now this is the, if you get the caliper, just check this caliper, and if you go there, you can see the TR gradient is almost 86. And we know the IVC is dilated. You can get the IVC dilated 15 mm more. That means the pressures are here. RV pressures are almost 86 plus 1500. And what is your systolic pressure, systemic pressure? Show there. So by all means, it's more than systemic pressure. So if you see the upper saturation 93 and lower pressure also low. So that means it's a shunting. If the PDA is there, that means it's shunting right to left. You can get up to that. And now you can measure the pressures are more than systemic. That means the suprasystemic PA pressures. So this is the first thing. So you can measure the PA pressure like this. This is the first way to do. So that will know only systolic pressure. Now what we'll do? See, if this is the first, go show here. Now this is the first apical. Now we'll go with this marker on the right shoulder and vertical. So this is known as, and you invert it. Show here. See. Okay, this is on the left side, and you can see. This is known as the parasternal long axis. You can see this is the aorta, LA, LV, and this is the RV. So if you see here, you can able to see this is some MR because it's going away into the LA. And then if you go anterior, you will see the pulmonary artery from that. If you tilt posterior, you will again see the tricuspid valve. You can show my hand movement here. If you go anterior from this fourth chamber, you will see the pulmonary artery. And if you go posterior, you will able to see the pulmonary valve. So this is in the same place, just rotate towards the right shoulder. Then you are able to see what? See, you are able to see this is a short axis view. Beautiful RA, RV, and see this is beautiful tripod sensing. See, this is the pulmonary artery which is getting divided very early. See, these are the two branches. This is the third branch, which is due to the PDA. So that is not the tripod, and this branch is dividing very early. So this is MPA. Okay. So with all means, you can able to tell that. See now. Okay, you see, I think we're able to see it well. See, these are the main branches too. And if you tilt little bit, and there is a special you just show here from the short axis, go up and make it vertical. You can see this is the LP and this is the so huge PDA. You can see if you put. Now I am putting the Doppler here. See. See, it's only showing the lower. That means the PDA is only shunting, and we expect because we got the PA pressure of 90, which is more than systemic. That means it's going from the PA towards the aorta. So that is related to that. So it's all showing the hypertensive PDA. You can see here again. Okay, these are the two. See, this is the RPA. This is the LPA. Now you can able to see this is a tripod. 1, 2, 3. So this is the upper, this is a huge PDA. So long means that big PDA in a neonate, you can see. Okay, this is 8 to 9 mm PDA. So by measurement also it's large, by PA pressure assessment also is large, and by hypertension also it's a large. Okay, so now once you go little, you have to extend the neck to get the good arch view. So what you do, just put like this. This is the arch, you can see. See, this is the arch. So first branch, second branch, third, all three are equidistant. But if you see, there is a mild narrowing. This is all irregular. So there is a coarctation is there in this baby. If you put color, see. So how the color is coming, you have to see. This the probe is there. Whatever it should be go as a blue color. But you will get some red color also. Why? Because of two reasons. Because of the PDA with large runoff lesion, it will go reversal. Diastolic will be low. And second thing, any low cardiac output, body will try to shunt blood from every other part to the brain. So you will see the low cardiac output, will see the reversal of the shunt, reversal of the flow in the aorta. So you can see here, this is again the tripod view from the supraesternal. You can see now beautifully this. the RPA, LPA, and the pulmonary artery. So you can see my probe position. It's from the 11 to 5, and then you have to tilt right and left to get the best position. So now you saw, and now come here. I'll show from the beginning. This is the subcostal. You will see the IVC. Go towards the left, you will see the aorta. Come towards the right side, you will see the IVC, left side towards the aorta. Apex, the marker should be on the left shoulder. Like this is a 4-chamber view. Go little anterior, you will able to see the aorta. More anterior, able to see the pulmonary artery, but not in the same plane. In the same way, go up at the second and third space with the marker on the right shoulder. Little horizontal probe, you will see the parasternal long axis. If you go more anterior, you will see the pulmonary artery. Posterior tilt, you will see the tricuspid. In the same place, move towards the right left shoulder. This is a short axis where you see the aorta in the center, RA, RV, and the pulmonary artery, in which is getting divided. Okay, and then if you in the same view go up and vertical, you will see the pulmonary artery that is known as the ductal flow and the tripod side. And if you go to the supraesternal is vertical, here you will see between 1 to 5 with the probe position with little tilt right and left, will able to see the arch. Okay, in the same way, if you put a horizontal, you will see here, you can show here. Just a minute. This is known as the crab view. See, if you put the horizontal, you will see the IVC is the innominate vein. This is RPA aorta, and this is the LA. And if you put the all color here, see, you will see the pulmonary vein is coming here from this side, this side. That means 3 are well seen here. 1, 2, 3. So that means it's a crab view. That means pulmonary veins are normal. So in that way, in the last, in the subcostal, if you go more detail, see, this is the IVC. Go to the left side, we'll see the aorta. And then if you see the horizontal, show here. Now this is a long axis of the subcostal. You'll able to see, put a color. Now show here. You will see the structure. This is the RA, this is the interventricular septum, this is the LA. And now you see this is the PFO. It is shunting left to right as well as right to left, bidirectional. Okay. So here also you can do the same by showing the like an apical. You go little anterior, able to see the aorta, and you go more anterior, you can able to see the pulmonary artery. How this is pulmonary artery? See here also is dividing very early. This is the very best view to say. I'll show again. See, this is a tube which is getting divided. This is a pulmonary artery. Aorta, if you see even in long axis here, you will not see any branching. See, this is aorta long. There is no branching of the aorta except for the coronaries if you are able to see. So that means it's a late division. So now these are the things. Second thing, now we come to the pressure thing. Again, I'll show. This is blue is the TR. If you put a pulse Doppler with the point at the where the origin, we'll get this is known as profile, Doppler profile. To get, you are getting the 67 pressure, 65. 65 was 15. Now the 83 is the pressure, and the systolic pressure is 18, and it's almost systemic PA pressure. It's not a systolic. Okay. And then, okay, this is the first thing. Then this is a fluid responsiveness we told, PA pressure we told. And if you get the PR, unfortunately here no PR, but if you see the PA directly, see this is the gradient, you can see this is the pulmonary art, this is the PDA. If you see the PDA directly, it's a right to left, and that means the pressure is equal to the systemic or it's more than systemic. Okay, otherwise if you put a Doppler here and you whatever pressure you will get, the difference that will give you the PA pressure. So this is the PA pressure. Now the last cardiac output, you see, we consider it as a circle. So what we'll do, you get first a long, the parasternal long axis. Take the measurement caliper here. Then this is the, sorry, just a minute. This is the caliper. This we are seeing as the annulus of the aorta, that means LV, that means coming 6. So what will be the radius? 3. So pi r square. Okay, that means this area of the this LVOT. So there's a one thing. Second thing, what to do? Then go the five apical chamber and go little anterior tail, then put a Doppler, pulse Doppler here. Not if you put, see. So now trace. Sometimes it's not coming here in this machine, but suppose you have to trace that like this. So suppose whatever trace VTI coming 118 point centimeter per second. Okay, that VTI multiply by the area of the circle what we got with the radius, that will give the stroke volume for the patient, and that stroke volume multiplied by heart rate will be the cardiac output, and if you multiply body surface it will be the body surface, means cardiac index. And second thing, now the position of the RV, and there are two lines now, just flush little venous line. Sometimes they will tell you to how where the flush is there or not. Flush venous line please. What we'll do, umbilical venous line will be in the ductus venosus, through ductus venosus. No? So we have to flush and see. See, this is the IVC. So whatever we flush, that should come through this. See, these are coming. The continuous flow, so you can see there is some flow is coming into the IVC. Just flush 2 cc. Purge. Umbilical venous line, just. No, just the UVC inotropes are going on. Okay, but just purge 0.1 cc. So see, after purging, suppose you do the NS, and then you will come to know, see, this is a continuous flow from the venous. That means it's correct. And in the same way, you can see the artery also. The artery, and you can purge, you can see the position of the artery. So in that way, you can able to see the UVC, UAC. In the same way, if you put a center of PIC line, you can purge, and you can see whether it's coming from the SVC or it's coming from the IVC. So these are the things. Okay. You can see now the beautiful PA getting early division. Okay. So in general, and apart from that, just check always liver. If you find something abnormal, just check always brain. If any edema, anything is there, you come to know about the. So this is in short. See, the issue is that the more you do, you more able to get it. No, in PG and all, it's always a guided teaching, and ultimately everyone has to swim alone. People may guide you, train you, but ultimately until you have to do practice. So you see all this basic. RA how looks like, RV also looks like, what is the comedendage, which valve is lower, which valve is up, which is more irregular. And what you do, just see. If you see pulmonary wall, you put a color. There is no turbulence. That means there is no PS. In the same way, no turbulence. That means there is no AS. In the same way, if you put up, like in the aorta, see here you can see this is known as turbulence. See, you can see some yellow. This is known as mosaic pattern. That means there is a mild turbulence in the aorta. It's a mild coarctation is there in presence of large PDA. So this how you'll able to know. And suppose you want to know what is the gradient across that, same way, take a Doppler, put a, if you want to, see not much gradient because PDA is supplying the hardly it's a 8 to 10 gradient, but there is some mosaic pattern. That means there is some turbulence is there. So like that, you can come to know where the IVC, what is the IVC dilated, whether UVC is connected normally or not, or whether UVC is rightly placed or not. With the changes, but this should always be left side, this marker. Okay, and this is the upper lower, you have to change like this, and then this is the color. Okay, this is the 2D, this is the Dopplers, PS Doppler all. This is the M mode. Now finally M mode, I forgot. So how to do the M mode? Take this parasternal long axis. Just put the M mode at the tip of the mitral wall. More horizontal, it will be better. So see, I always told in systole it will be less. So this is the, if you see here, this is the LVIDS. Okay, and this is the diastolic flow. Okay, so you can see this is the, but if you see in the machine, there is a one button, calculate, EF. You can directly calculate. See, once you come this side, it LVIDD, I put it here, and I put it here, select. Okay. Okay, this is save. So to save and then LVIDS, then this select this save. So you see EF is coming 60 and FS is 61. So this is how you are able to see. So this is M mode, pressure gradient we do. And second is the same way in the period LA aorta volume. There are two ways to do it. Either do separately. One, the wall should be open for that. It should not be closed wall. Okay, then all you know how much it's coming. We already told it's coming 5.8. And then the LA should be in the closed mitral wall and aorta should be in the open mitral wall. Open aortic wall, sorry. See, this is the maximum. So 6 was there, and now this is the LA 10. So 6 by 10, that means it's around 1.6. Okay, and in the same way, there is one more clue I will give you. Whenever you are seeing the LA, your PA will be, aorta will be always just back of that. So there is no gap between LA wall and aorta. But if the gap increase, that is suggestive of your TAPVC. If this ridge is not seen, that is more suggestive of TAPVC. So you have to get this clue from that. And in the lower, I told you, if this is only IVC and aorta, there is no third vertical plane in between. That is not having descending over pulmonary vein. So this like that you see. So if you are able to do that, you're able to, like pressure we told, IVC we told, then M mode we told, now TR and PR, how the pressure gradient across the shunt, what are the different views. The more you will do, more you'll able to get it. So apart from that, always see X-ray. Suppose you are not getting pneumothorax will not allow, pneumopericardium will not allow us to see. Then last thing, one word we also use to as a cardiologist, we are seeing. See, this is the flare that you know in the lung scan, but there is no collection. This is a lever, this is a diaphragm. So diaphragm is also moving. There is no diaphragm pulse in the same way. Left side, you can see there is a diaphragm, the left lung collapse, but the diaphragm is moving and the spleen is seen. So that means there is no palsy. So like post-op patient will see the diaphragmatic palsy, pleural collection. So like that. And third and last, if you see any four, like if you are seeing the long axis. See, this is the flare is the pericardium and inside that is the myocardium. So there is no clear-cut space like this black. There is no pericardial collection. In the same way, when you are doing the short axis and do the posterior tilt. See, this is the myocardium. And there is a pericardium. There is no black fluid line in between. There is no pericardial collection. So you saw pericardial collection, pleural collection, IVC, PA pressure, all chambers, 4 chambers, and what are the views. The more you do, you more able to get it. And along with that, always take clue from the X-ray. Always take from the clue from your other finding how to check for the lines and all. So thanks for your kind listening. I think it would be helpful. It's only beginning. The details are more. The more you do, you're more able to get it. Thanks a lot. Have a good day. Okay.